Should I just get started or?
No. So we need to make the introduction.
Okay.
And while we're waiting for people to join,
Okay.
there will be probably a bunch. We also will be recording and broadcasting this presentation afterward. Dominika, you are recording. You probably are aware of the longevity medicine education hub. It's probably one of the largest education hubs for physicians and medical professionals in the world, with more than 7,500 medical professionals who have registered for the courses, and now many of them are practicing longevity medicine, mostly by doing clinical trials using aging biomarkers and the knowledge that they acquired during the courses. Many of them are now attending either in person or virtually the largest conference on aging research and drug discovery in Copenhagen, which this next year will transpire 25th to 29th of August. This community would not have been possible without the efforts of multiple PhD and MD PhD scientists from around the world working on a volunteer basis, and nowadays carefully coordinated by the management team, today coordinated by Dr. Evelyn Biskup, who is here, MD PhD. So on the call today with us is also Dominika Vilček, who is one of the volunteer coordinators of the Longevity Education Hub, and now is taking a very significant management roles. We will have more people joining, and I hope that we'll be able to broadcast this lecture to a broad audience. Maybe Dr. Evelyn Biskup would like to make the introduction.
With great pleasure. Shall we maybe give it one more minute, or would we like to? Actually, no, we have quite a good number already, and potentially we can start. So, welcome everyone, and once again, a great thank you to Professor Kuchel for taking the time out of his extremely busy schedule and to share with us something about our core interest and our core importance that we put into educating physicians, and not only physicians, in longevity medicine. So as Professor Jaworonkow mentioned before, this course, this platform, now this hub, and actually a whole curriculum was developed in order to educate physicians, clinicians, and then also all healthcare professionals, therapists, nurses, and also a lot of students and people with general interest took the course. However, we were really focused on creating a curriculum for medics and also get it approved by American Medical Association with CME points. It's still the first and the only ones to be approved for educational purpose for longevity medicine for physicians, in a way that we could take it later also to universities. And as of this year, our curriculum is in 3 universities around the world, in 2 of them as obligatory part of the medical curriculum, which is for us, of course, a great honor and gratitude and pleasure. This is a voluntary effort. This is a fully free course and fully free curriculum. Everybody who was working on it from many countries worked based on their passion and the belief that we can only create the real translation from geroscience to clinical practice if we educate physicians and educate our future educators. And that brought us also to this topic of the webinar. So our webinar series has been going on for about a year now. However, we were focusing previously on announcing some of the important features in the field. We had a great pleasure to have Professor Jamie Justice talking about the X Prize. We had the great pleasure to have also other scientists talking about the updates in the geroscience and clinical trials. We had the opening with Dr. Brady Gray. However, this webinar will be focusing primarily on education, and that brings me to introducing our speaker just with one line. So Professor George Kuchel is a professor of medicine, geriatrics and gerontology, and director of the UConn Center of Aging. But what is the most important for me in all of the conversations we had all around the world was really also his passion for education, not only for medical students, but also medical residents and physicians, senior physicians, and the senior planners of the hospital. He is also one of the leaders, actually, the Translational Geroscience Network, where he is constantly also engaging and seeing the gaps that we have in the education of physicians. So with this, I would like to open the webinar, and Professor Kuchel, once again, thank you so much, and please feel free to add on your introduction.
Well, thank you very much for that kind introduction, Eva, and I'm honored and pleased to be here. Hopefully everybody can see my slides. Let me just, can you see my slides?
Yes.
Yes, we can see the slides, but maybe we also should introduce you more deeply.
Okay.
Yeah, so Professor George Kuchel is a medical doctor with many years of experience. He's a professor of medicine and also the Traveler's Chair in Geriatrics and Gerontology at the University of Connecticut. He is also on the board of XPRIZE, which is probably the largest prize for longevity right now. He focuses on precision gerontology and geroscience. He seeks to connect and enhance the function and independence of older adults by targeting heterogeneity in age-related declines involving host defense, mobility, cognition, and bladder control. He also leads the University of Connecticut Older Americans Independence Pepper Center, the NIA Geroscience Education and Training Network, and the KAPP-Sen NIH Common Fund Cellular Senescence Tissue Mapping Center. Dr. Kuchel is also serving as MPI to the NIA Translational Geroscience Network, and he is in general a celebrity in the field, very relevant to the longevity medicine education hub. Welcome, Professor George Kuchel.
Thank you so much. And I don't know about celebrity, but it's my pleasure and honor to be here with this group that has done so much to advance the fields of aging and geroscience. So I don't have any commercial disclosures to share. In terms of what I'll talk about today, I'm going to share some thoughts with you in a couple of parts and touch upon a number of different areas. And I'm happy to answer questions at the end, and I'm of course happy to come back some other time if there's interest in hearing more in more depth about any one of these areas. So I'm going to kind of share with you that what has now become so-called traditional story of geroscience and the excitement and some of the limitations that we're experiencing. And share with you some thoughts about how we can accelerate the progress from bench to bedside, which is what we all want and which the field desperately needs. I'm going to give some examples of work that we do of geroscience guided applications in vaccine research as an example of research where it's actually possible to study gerotherapeutics with a much shorter time frame. You can look at effects in the context of weeks or months as opposed to decades, which is what occurs when you're looking at outcomes such as mortality. I'll mention the role of research networks because I think that geroscience is very much a team sport, like everything in aging. But being such a new field, the role of networks is incredibly important. And I'm also going to talk about as a clinician and geriatrician, I'm going to talk about how geroscience is going to address the remarkable multifactorial complexity and heterogeneity of aging, and because without that, it's not going to work. And then I'm going to end up talking about the role of geroscience education, which I think we're all passionate about. So it's a lot to cover here. So I think everybody has seen data like this showing that traditional cardiovascular disease risk factors listed here, everybody's familiar with these, are incredibly important. increases of up to 80%, smoking, high blood pressure, high cholesterol, diabetes, yet they're dwarfed. When you look in contrast with aging, they're orders of magnitude much less. So aging is by far the most important risk factor for cardiovascular disease at the population level. And similarly for Alzheimer's disease, where risk of Alzheimer's disease increases 97-fold between 50 and 75. And then when you look at all the other risk factors of Alzheimer's disease that we focus on, ApoE4, being female, hypertension, smoking, physical activity, and diabetes, the entire risk is tenfold. So again, these varied risk factors that we tend to focus on are dwarfed by aging. So all of this, everybody has seen this figure here. The observation that aging is by far the major risk factor for most of these chronic diseases has led the geroscience revolution, as we will. And the two, I like to think the two foundational events that beyond that really propelled, that initiated the geroscience hypothesis and movement has been the National Institute on Aging ITP Interventions Testing Program, which in 2009 published a seminal paper showing benefits of rapamycin in extending lifespan in genetically heterogeneous mice. Subsequently shown, some similar effects were shown for healthspan and other publications. And then also a series of studies published by our colleague and friend Joan Manick. This is when she was at Novartis, in showing that mTOR inhibition improved immune function in older adults living in the community in Australia and New Zealand in terms of vaccine responses. And then this is just to illustrate the fact that those studies focused on mTORC1 inhibition as opposed to mTORC2. And this work is still ongoing as everybody tries to develop much more specific agents in terms of specificity for mTORC. And the interventions testing program, the best way to think about it is a clinical trials network for mice designed by NIA, really a very visionary program based at Jackson Lab in Bar Harbor, Maine, University of Michigan at Ann Arbor, and University of Texas Health Sciences Center in San Antonio, trying to test longevity molecules, health span, lifespan enhancing molecules in a very rigorous, standardized way with identical protocols at 3 separate sites, as rigorous as can be done. And I just want to mention that anybody can actually recommend. There's a solicitation every year for molecules to be tested by the mouse ITP program, as there is also for the C. elegans program, which is a separate program similar to this. And anybody can recommend, and they're reviewed, and if they're accepted, they'll be tested, and you'll be a co-author in the study. And there have been wonderful examples. This is what actually happened with rapamycin, and this is the kind of benefits that were shown in lifespan, and these actually are very dramatic effects when it comes to mouse lifespan, and healthspan effects were also published subsequently. And then in terms of mTORC1 inhibition, a series of papers from Joan Manick's group who I mentioned that still is ongoing where she's now working at other companies, have shown improved flu vaccine responses in older adults, as well as decreased upper respiratory tract infections. So much excitement, and these are the kinds of effects that this is respiratory tract infections per person per year, and you can see that using these mTORC inhibitors, either alone or in combination, had some significant effects there. And again, there's ongoing work to improve the specificity of these agents and their effects. So how do we move gerotherapeutics from an idea to reality, which is, I think, what all of us in the field are passionate. That's why we wake up every morning. And one major challenge is, as illustrated here, for everybody here who takes care of older patients, or even if you don't and you have family members who've grown older, this heterogeneity of aging is a uniform theme that really applies to everything that we see in aging. Here in illustration, I'm just illustrating the heterogeneity in physical function with aging, where we all have friends and colleagues and patients who run marathons into their 80s, climb mountains and downhill ski, and we have people who are bedbound and all kinds of degrees in between. So the heterogeneity is something that is uniform in everybody, and everybody has seen this picture of hallmarks of aging. This is just my illustration here, and it's been developments in the biology of aging addressing the role of cellular senescence, altered intracellular communication, epigenetic changes, mitochondrial dysfunction, deregulated nutrient sensing, proteostasis loss, stem cell exhaustion, telomere attrition, genomic instability, and others, has really raised the excitement that if it would be possible to attenuate, to slow these biological hallmarks of aging in older adults, then one would be able to push back on this incidence of comorbidity or chronic conditions. This is data from the Olmsted County database in Minnesota, showing that with aging, everybody's well familiar, you have this exponential increase in chronic conditions. This is incidence of 3 different chronic conditions, any 3 chronic conditions. And the idea has been that it was geroscience. If the geroscience hypothesis works as we've postulated, and there's increasing evidence that it may, that these interventions with drugs targeting biological hallmarks of aging, and as well as, and I'll talk about it at the end, lifestyle interventions that promote healthy aging, because these cannot be studied in isolation, it'd be possible to push back the onset and progression of multiple chronic conditions, as illustrated here with the yellow arrow. Unfortunately, and I think there's tremendous excitement about this, and I have to say that in my career, the field of aging has changed remarkably. I mean, there's never been a more exciting time to be in the field of gerontology and geriatric medicine or geroscience than now. Very, very exciting. Having said that, I think we also need to be totally candid that the details of how we know a lot about the biological hallmarks of aging, and we know a lot about how people age and heterogeneity and multifactorial complexity. The details of how targeting the hallmarks is actually going to have the kind of effect that we want. There's still a lot of hopeful thinking, let's just say. I mean, I think that there's still a lot of work to be done. We're not quite sure how we're going to get there. And even when interventions do work, we're not always sure why they work and why one particular intervention worked, another one did not. We certainly have great ideas, but there's a lot of work that needs to be done. So I want to just change gears a little bit and talk about what happened during the pandemic, the COVID pandemic, because it was obviously a devastating event worldwide, tremendous implications. Millions of people died, and older adults were particularly vulnerable. But I think it taught us some important insights when it comes to geroscience that I think are worth mentioning, particularly with me suggesting that interventions into the vaccine, geroscience guided interventions into vaccine responses can allow to provide insights much more rapidly than studying outcomes like survival or development of new chronic diseases, which can take much longer. So this is CDC data that actually came out in the very first few months of the pandemic, long before we had effective vaccines. All we had at this point was basically good public hygiene measures, masking, traditional public health. We didn't have any vaccine for COVID-19. We had some people who had antibodies to other types of coronavirus who had some degree of protection. But the bottom line is what I want to focus on. If you look at the comparison group being 18 to 29 years old, young adults, people who are 65 and 74 years old had a 90-fold increase risk of death from COVID-19. And a 5-fold increase of hospitalization. That's astronomical. When you study risk factors, epidemiology, that's unprecedented, absolutely unprecedented. And when you look at people 85 years and older, before vaccines, the risk of dying after being exposed to SARS-CoV-2 was 630-fold higher. I mean, this is unprecedented. This is almost certainty when it comes to epidemiology. So what's behind this? And I think we've learned quite a lot during the pandemic. One is that chronological age alone is not the whole story. And this is just a couple of examples from the early literature. An 102-year-old Italian woman who recovered from coronavirus, from COVID-19. This is a woman in Long Island, in New York, who's 101 years. He was 101 years old. This was back in 2000 or so, and who beat COVID. And this is a woman, 102 years old, published in CNN, who actually managed to live both through the 1918 influenza pandemic and the COVID-19 pandemic. And again, clearly, chronological age is not the only factor. There's something different about these people. They're much older chronologically, but there's something different about these ladies that protected them. There are some insights, biological insights. This is a a paper published in Cell in 2020 by a prominent immunologist, French immunologist who's at Rockefeller in New York, Jean-Laurent Casanova. And this is to highlight the fact he's done a lot of work to identify who are the people who are particularly resistant and particularly vulnerable to COVID-19. And if you just look at, I don't know if you can see my mouse, but if you look at, age is on the left axis here. This is vulnerability. This is people being exposed to the virus. There's age on the y-axis and comorbidities on the x-axis. And you can see that severe disease is in red. So being older and having more comorbidities was the risk factor. But there are some people who have rare but unexplained resistance to infection, such as these ladies here, who just did really well in spite of being chronologically quite old. And then others, young people, there have been tragic cases of young people, people in their 20s, who had to be intubated. Some didn't survive because they had inexplicable sensitivity to COVID-19. It turns out Casanova's group published, there's data that they have antibodies. Basically, their interferon gamma signaling system is impaired due to mutations and/or autoantibodies, and they're just much more vulnerable. Well, what about everybody else? What about everybody else who's kind of in between? And that's really what we need to focus on. What about all of these people here and here and everybody in between? So the heterogeneity of aging is something that we tell our students about. We say, as a former mentor of mine used to say, you've seen one older person. You've basically seen one older person because we're all different from each other, and we get more and more different from each other as we age. And this kind of belies the traditional view. This is a picture from Middle Ages, 17th century view of man's progression through life. And the idea being, the way we've traditionally viewed aging is that there's this rise from being a child to there's development, maturation, all the way to the sum of perfection. I guess this is when you become a tenured professor, then you're perfect. And then everything from that point on is this inevitable linear progression downwards. And in fact, we know from our clinical work that and published literature, there's tremendous heterogeneity in terms of how people age. Some wind up in nursing homes because of major needs. Others contain to live independently and with high function, and lots of people in between, as shown, as illustrated here. So tremendous heterogeneity. And to illustrate how to think about that in the context of COVID-19 infection. So if you think of the virus infecting cells, people being exposed, you can think of their immune defenses as this castle here, as illustrated here. And if they're strong and people are healthy, then from a resilience point of view, and I'm a big proponent of addressing resilience with aging, in this case, immune resilience, the people are able to respond to the infection, clear it very well, and their function may decline minimally, transiently, but they return back to normal. Now, what happens when you have much greater amount of virus, or when you have people exposed to a virus they have never seen before, which was the case for the vast majority of individuals who didn't have antibodies to coronavirus, particularly in the context of immune aging, when the defenses are impaired, what you then see is you see people for whom it takes who have much greater declines in function. It takes them longer to recover, as shown in red. And there are some who never recover and some who die, as shown and stippled here. So the whole idea of addressing biological aging in this way is to reinforce the castle here, as shown by repairing the bricks, if you will, which can be done, we believe, by targeting biological aging. It, of course, can be done with vaccines and antiviral drugs. But the strength of targeting biological aging, all of these approaches are important, is particularly important, as it was with COVID-19, is when you don't have an effective vaccine yet. Because, of course, it takes time to develop a vaccine, even with all the revolutionary advances that have been made in the last few years, particularly with the mRNA delivery platform. So the attraction of targeting biological aging is that these strategies should ultimately work with geroprotectors, should ultimately work, as illustrated in this slide. This actually published with Jamie Justice, who you mentioned earlier, illustrating that if you target older adults with a geroprotector, and the example we used here was metformin, but it could just as well be mTORC inhibitors or other gerotherapeutics potentially, that what happens is that potentially irrespective of the infection, of the virus, the strain, or the infection, you'd be offering protection as shown here in the stippled line, as opposed to in terms of baseline function, risk of hospitalization when people's function really declines below this threshold, and then recovery. So that could be transformational because it could protect almost regardless of it's focusing on the patient rather than on the infection, which is a very different way of viewing infectious diseases. So potentially transformative. So why metformin? Everybody's familiar with metformin in terms of how it works, lowering glucose in type 2 diabetics and other effects shown here. But ultimately, from a gerotherapeutic point of view, metformin is attractive as one of many different drugs which have beneficial off-label effects. We tend to think of drug effects in older adults as having harmful off-label, off-target effects, and that's generally the case. But more and more now we're learning about drugs that are used for one indication and yet have potentially beneficial, potentially gerotherapeutic effects across different biological pathways and conditions. And this is just shown that it has major effects on deregulated nutrient sensing, mitochondrial dysfunction, as well as these other hallmarks of aging, and ultimately major effects on chronic inflammation, which is perhaps a little bit more downstream of all of this. So metformin has these attractive features, and I want to just share with you a couple of papers that have come out recently in high-profile journals. This is conducted by Carolyn Bamonte from University of Minnesota, who's done she and her team have done some really landmark work in the context of COVID-19. This is a paper they published in New England Journal of Medicine in August of 2022. Very complex design, innovative design, comparing metformin, ivermectin, and fluvoxamine for COVID-19 outcomes. The short of it is that they saw no benefits for the second and third, but there were some benefits for metformin. Unfortunately, they don't appear in the abstract or are not really discussed in the paper because the journal did not allow them to mention the outcomes, although they were predetermined in terms of delay, in terms of decreasing hospitalization. They were secondary outcomes. So that's a whole separate discussion in itself. I have some very strong views on that. And the same group also published a trial, again, an RCT, multi-center, quadruple blind phase 3 trial, which show benefits of randomization to metformin in the context of preventing long COVID. And this is the data from that study where you can see these were randomized people. Long COVID is a complex condition, but in this trial, clearly people who are randomized to metformin were much less likely to develop long COVID. This is cumulative incidence, and look at the blue curve as opposed to the red. So these are important studies, which interestingly enough, published in high-impact journals, but the word geroscience or aging did not appear anywhere. So it's kind of interesting. And we can talk about this at the end. Our group is doing studies, and I also mentioned some selected examples of work that our group is doing or has done. Jenna Bartley, an assistant professor in our group, has been funded by FAR and NIA to look at effects of metformin, and this is just highlighting also its broad effects on the immune system, as illustrated here is the anti-inflammatory properties. And she conducted a small proof of concept study called VEAM, to look at effects of metformin influenza vaccine responses on non-diabetic older adults. And the effects were relatively modest, and we think because she targeted people who were non-diabetic and actually very healthy, but there were some improvements, particularly decreases in some exhaustion T-cell markers, but they were not as striking as we would have liked, and this is why we think the study needs to be done now in people who are diabetic and also have more comorbidities, and that's planned for the future. I want to switch gears to talk a little bit about cellular senescence, and in this year we actually lost two seminal figures in the field. Leonard Hayflick passed away, who associated with a Hayflick phenomenon of cellular exhaustion and limits to replicative senescence. And Judy Campisi also passed away this year at a younger age, who was responsible for identifying SASP and many of the properties of senescent cells. I want to just go quickly through cellular senescence. Many of you are familiar with this. We know that cells can become senescent, not just because of aging per se, but also DNA damage, telomere dysfunction, mitochondrial defects, metabolic stress, oncogenic insults. These cells can no longer divide. They also can't die. They secrete all of these molecules as part of the SASP, senescence-associated secretory phenotype, mostly cytokines, chemokines. And this is how you identify senescent cells in terms of markers of DNA damage, as well as P16, P21, and many other markers I'll talk about in a minute that people use. And these cells accumulate with aging in many, many different tissues. And this is a seminal paper published from Jim Kirkland's group and others, which did an siRNA approach in senescent cells and identified these nodes. And this highlights the fact that with senolytics, drugs that basically allow senescent cells to die, you actually need to have drugs that are dirty. It's a very different approach to drug design. You need drugs that target multiple of these nodes. And this is data where they showed that these two drugs, particularly when used together, dasatinib, which is a tyrosine kinase inhibitor, which is FDA approved for chronic leukemia, and quercetin, which is a nutraceutical, it's a flavonoid. If used together, they work very well in terms of allowing senescent cells both in pre-adipocytes and also in endothelial cells to be cleared. And that has led to a whole series of studies. I'm going to just mention one study by Ming Zhu in our group, who showed that basically a combination of D and Q administered intermittently, not on a regular basis, works very well over 4 months, to 20-month-old B6 mice, resulted in very important benefits in terms of physical performance and frailty. And this study and many others done in different conditions have led now to multitudes of different studies examining the potential benefits of senolytics for a variety of different conditions involving in the lungs, in kidneys, joints, brain, ranging from interstitial pulmonary fibrosis all the way to Alzheimer's disease and everything in between. So a lot of excitement in the field about this. So I want to just highlight the fact that in the context of immune resilience, which I told you was a wonderful way to study the issue of gerotherapeutic on a much shorter time scale, I want to just highlight the fact that as promising as senolytics are, things are not always as simple as we would like them to be. I want to just illustrate two examples, one from the field of vaccine research from our own work, from our own group's work, and the other one in the context of urinary incontinence, which is a very common and very understudied problem, also from our group, just to illustrate that things are not always the way we'd like them to be, and sometimes the answers can be much more complex. So this is work that was done by Laura Haynes in our group, by Blake Torrance, who was a graduate student with her, who infected P16 3MR mice, and he showed that clearance of P16 positive cells, which this is a mouse developed in Judy Campisi's labs, and has enhanced viral clearance, but actually decreased immune memory in terms of flu-specific CD8 positive T cells and lung flu-specific antibodies. So immediately you can see that senescent cells are not always bad, and they can actually have positive effects, and clearing them here in the context of flu infection in mouse models has both beneficial and potentially harmful effects. Blake also tested the two senolytics I mentioned, dasatinib and quercetin, and found that this combination, while helpful for frailty and many other conditions, did not improve overall responses to influenza infection in aged B6 mice. And then finally, work from Erica Lorenzo, who also worked with Laura, showed that in lungs of flu-infected aged mice, senescent cells appear to mediate upregulation of Treg cells via cytokines such as TGF-beta. Again, may potentially have beneficial effects, but the details still need to be worked out. Bottom line is, we're not ready. There's no data to support the use or testing of senolytics to enhance flu vaccine responses until we understand this much better. Oh, and then finally, there's data to also show that quercetin promotes NK cell, natural killer cell maturation. So again, very complex effects that we're just still beginning to understand. I want to switch gears quickly to some work that we've done in context of lower urinary tract function and incontinence. This is an area actually that I've personally worked in for many years, going back to when I worked with Neil Resnick at Harvard and others. We've done some of the seminal work. Iman Al-Nagar, she was a postdoc with us when she did this, but she's now joined our faculty. And this just came out in Aging Cell, I think yesterday or the day before, so you can look it up. But the bottom line is, what I'll highlight here is that we found that, yes, there are senescent cells in the mouse bladder, not surprisingly, but there were two major surprises. One was that, at least in our studies, DNQ used by gavage, done the same way we've done it for frailty, other conditions, had actually no benefit in terms of physiology, in terms of urodynamics, which is what you actually care about, and there are many potential explanations for that. The other is that the bulk of the senescent staining was in uroepithelial cells. However, it's a very different kind of senescence that we're talking about here. Senescence, it's not associated with DNA damage. It's associated with polyploidy. And we think that these cells are senescent, that it's beneficial senescence to actually protect the bladder from being exposed to this caustic environment in the urine, and to prevent uroepithelial cells from becoming malignant. But it's a whole different topic, but just to highlight the complexity. So again, this is the geroscience hypothesis listed above, and I talked about that. The bottom line is, and this is from a paper that we published a couple of years ago, is that geroprotectors are not only senolytics, as important and exciting as they are, they include many other compounds as listed here. The other take-home message here is that, first of all, the biological hallmarks of aging, they're not separate pillars. You influence one, and I'll get to this at the end. They all influence each other. There are a lot of horizontal and downstream effects. And also these drugs, they work by not targeting specific molecules. They target multiple molecules and multiple hallmarks of aging. They may have a predominant effect on one hallmark, but they target multiple hallmarks of aging. And perhaps that's why some of these work. So switching gears, in terms of still the lower urinary tract, so the same Iman Al-Nagar, who I mentioned earlier, who's now joined our faculty, has done a remarkable transition, which in my entire career I've never seen. She's gone from being her PhD in cell biology is in cell biology. Her whole career has been in doing cell biology. She decided that she wants to do clinical trials, and she became. She's now on training with us through our Pepper Center and support from the American Urological Association to become a clinical trialist with a focus on applied translational geroscience. And she decided, because of her data, that the way to target the bladder was not going to be with senolytics, or at least not DNQ, but rather by targeting inflammation, oxidative stress, and mitochondrial dysfunction, deregulated nutrient sensing, which are important risk factors for aging, for metabolic syndrome at the bottom, and this important interface between the two, which involves cardiovascular disease, type 2 diabetes, and lower urinary tract symptoms. And aging and metabolic syndrome are two major risk factors for lower urinary tract symptoms and incontinence. So she proposed a hypothesis to test MitoQ, a gerotherapeutic, I'll talk about it in a minute, that we have no effective treatment now for lower urinary tract symptoms. The clinicians will know that the only drugs that are, well, there are two categories of drugs approved: anticholinergics, which are toxic in older adults, and beta-3 modulators, adrenergic modulators. But this would be a transformational approach because it would target the root causes of lower urinary tract symptoms if this were to work. And MitoQ, just very briefly, is actually considered to be a nutraceutical. It's a mitochondrially targeted form of coenzyme Q. It's an antioxidant that's being formulated to be taken up actively into mitochondria through this covalent modification. It's lipophilic, and it's been shown to improve mitochondrial endothelial function, increasing nitric oxide bioavailability, reducing oxidative stress and inflammation. And this is just illustrated here, that it has these effects on different aspects of different biological hallmarks of aging that we know are involved in the urinary tract symptoms. This is her protocol. She's recruiting, she's about halfway through the study recruiting women with metabolic syndrome, with both metabolic syndrome and LUTS, 50 to 75 years old. This is a study design. It's a randomized placebo-controlled crossover study with multiple time points and assessments, and we're excited. It's supported by our Pepper Center, and the outcomes are going to focus on self-reported questions, because that's what matters to individuals with LUTS, as well as physical cognitive assessments and very, very deep biomarker analysis, both in urine and blood. And just to give a shout out to Oh-Sung Kwon, who's another one of our Pepper trainees. He's actually a kinesiologist by training, who's also doing studies with MitoQ, and who actually has shown, this is an uncontrolled study, it's an observational study in which he was able to show that in older men with chronic lung disease, where he measured vascular flow-mediated vasodilation, which, as you know, declines dramatically with aging, one of the most important vascular changes you can see with aging, that, and again, these are very pilot data that there appear to be some potential benefits, both in terms of acute and longer-term 4-week administration of MitoQ. So this is kind of illustrating its overall effect. So he now is doing a study funded by KO1 and our Pepper Center, looking at benefits on MitoQ on vascular function, on nitric oxide bioavailability, endothelial function, as well as walking speed and cognitive function. So we're very excited about that. So I want to shift gear to networks. This is the Translational Geroscience Network, for which I am MPI, together with Jim Kirkland, Tamara Chkonia, and Steve Krzyzewski. And this is our website. I would encourage you to look at it. If you Google Translational Geroscience Network, it will get you there. This is from our website. We just got refunded for another 5 years, so we're excited to move forward. This has been an effort that has involved all of these institutions. As I said, Jim Kirkland and Tamara Chkonia from Mayo Clinic, they have just moved recently to Cedars-Sinai, as well as Steve Krzyzewski from Wake Forest, and myself and these other institutions. And this is from a paper that we published earlier this year in JAGS for the 50th anniversary of the NIA, just to illustrate what the TGN does. It was really designed to help investigators overcome the tremendous challenges, the barriers of going from bench science to human subject research. And those challenges are incredibly difficult for anybody, even somebody experienced at all of that. But what we found is that vast majority of people, vast majority of investigators are knowledgeable either in terms of bench science or clinical trials. Very few people are knowledgeable at both. So what we help with is we help with regulatory oversight, help with submitting INDs, statistical and data management issues, data deposition, and then facility for geroscience analysis is now, we have standardized protocols, and we do for over 100 different biomarkers in blood, urine, and other body fluids and nail clippings, for example, and also biobanking. All of these samples that we're generating through the TGN are being deposited at the NIA Biobank, so they can be available to researchers around the world when they apply to get access to these precious samples. And this is just an example. We're currently, the number keeps growing. At last count, 86 different studies are being enhanced. We don't have the funds to support the clinical trials, but we are enhanced by our network, and they range from everything from senolytics to metformin to rapamycin analogs, nicotinamide riboside, etc., targeting a wide variety of conditions as illustrated here. Again, I refer you to our website and to the JACS paper from earlier this year. They include both trials as well as observational studies. And just to be clear, the trials are mostly phase 1, phase 2 trials at this point, but a lot of excitement. So to shift gears to the SENNET network, just to tell you a little bit about the SENNET network. So this came about through the realization. This paper was published, actually, everybody here was at the time worked at NIH. Norm Sharpless, who many of you know, has been a pioneer in cellular senescence, has since left. He was director of NCI when this was written, and Richard Hodis is the director of the NIA. And it was really the realization that while the field of cellular senescence and senolytics is moving forward at a incredible pace. I mean, this is unprecedented. We've gone from early concept proof of concept studies in mice to clinical trials in the space of really just a handful of years, 2, 3, 4 years. Unbelievable progress, okay? And this is, you've seen all the studies that are ongoing with TGN and around the world. And at the same time, there are fundamental questions regarding senescent cells in human tissues, particularly in human tissues, that we don't know about. Senescence, we have lots of data about senescence in tissue culture, particularly in terms of involving cell lines, much less so primary cells. We have more information about senescence in animal models, mostly mice, but we know next to nothing about senescence or senolytics in humans. We're just beginning to learn. So the NIH has over the years funded major efforts such as HubMap to create high quality comprehensive maps of cells in various tissues that then are immediately shared with the community to be accessible by investigators around the world. So they proposed this, and what this led to is the creation of the SENNet network. This is from a paper we published in Nature Aging just as we were starting a couple of years ago, illustrating all the tissues that are being studied as part of SENNet. Not all the tissues, but many. These are all the centers around the US that are involved in this, including collaborators in Scotland and Germany. And this is just a potpourri of techniques that we're using. Of course, this is already outdated, but all different approaches to single cell heterogeneity, all the way from single cell RNA-seq, nuclear-seq to flow cytometry, CyTOF, as well as various approaches to performing spatial maps of senescent cells. And senescent cells, although they can't die in vitro, they're actually incredibly hard to study. And I don't know if people are aware, for example, senescent cells in blood die when you cryopreserve peripheral blood cells. That was shown by Norm Sharpless. So one has to be very careful when studying senescent cells, and it requires really new approaches. So the tissue mapping center that I lead, which is called KAPP-Sen, which focuses on kidney, adipose, pancreas, and placenta. I'm sure there'll be questions about placenta. Turns out that senescent cells actually play a very important role, beneficial role, essential role in placental formation and implantation and early embryogenesis, and can also play a very harmful role in a condition called preeclampsia, which is, anyway, so this is the tissues that we focus on. These are collaborating sites, and these are our investigators. Vesna Geriatrics is a nephrologist, also trained in OBGYN at Mayo Clinic. Nick Musey is an endocrinologist, diabetes expert who has just moved from San Antonio to Cedars-Sinai. And Paul Robson is a computational geneticist, runs our single-cell genomic facility that's shared by UConn and Jackson Lab. And so this has been a wonderful effort. I want to just very quickly mention that for those of you who are interested in cellular senescence, there are incredible challenges in studying senescent cells, defining what constitutes a senescent cell. I refer you to a paper that we just published earlier this year in Nature Reviews Molecular Cell Biology, where we did our very best to provide some guidance in terms of how to approach senescent cell diagnosis. It's different species, different organ tissues, very complex issue. So to get back to a patient-focused approach, this is the theme focus of our Pepper Center. Each Pepper Center needs to have a theme. Ours is on precision gerontology, which we really define as an effort to better understand the growing heterogeneity with aging across all dimensions, from biological aging all the way to social and behavioral and health outcomes and population level, as a way of developing more precise targeting in order to improve outcomes at the level of improved function and enhance independence in older adults. That's really the focus of what we do. And this approach, we really think this could be transformational. This is a slide board from Felipe Sierra, that this approach, the whack-a-mole approach to management of chronic disease prevention and management is incredibly unsatisfactory. And I think everybody's familiar, whether from your own clinical practice or what family members have experienced, is that the way the current healthcare system works, it focuses much more on treatment than prevention. And typically, when we treat a new chronic disease, what typically happens, once you've improved that chronic disease, the next one develops. Once you treat that one, the next one develops after that. So this has been incredibly frustrating. And I want to just say a couple of words about this whole issue of multifactorial complexity that colleagues and I have addressed many years ago in work that goes back actually a couple of decades, that everything you look at in terms of aging, particularly geriatric syndromes, has this multifactorial etiology. And therefore, and as illustrated here, therefore, for this to work, interventions to work, you have to focus on multi-component interventions that address predisposing and precipitating risk factors that work really best for prevention. Wonderful work, seminal work shown for delirium and falls, and also exercise, pleiotropic lifestyle interventions, and weight loss work in part, we think, because they're so pleiotropic. And more recently, drugs that have these potential off-target pleiotropic effects, such as statins and these new diabetes drugs I'll talk about in a minute, are very attractive. And we think that's how gerotherapeutics, potentially combinations of above, may work. So speaking of semaglutide SGLT2 inhibitors, another recent paper from New England Journal of Medicine showed dramatic improvements in physical function, 6-minute walk with semaglutide. Incidentally, another paper published in JACC showed that people randomized to semaglutide who happened to be exposed to COVID-19 had a lower mortality rate than people who are not on semaglutide, okay? So very important effects with lots of excitement of potential geroprotective effects in terms of diabetes, in terms of other chronic diseases such as Alzheimer's disease, etc. So why does all this work? How can all this work when you have this tremendous complexity, where you have hallmarks of biological aging that are upstream, others that are downstream, all of which interact with each other, and all of which represent important risk factors for these highly multifactorial, highly heterogeneous geriatric syndromes and other conditions? Well, this is from a chapter that we recently wrote for Hazard's textbook, that the idea is what we think may be happening, and again, this remains to be proven, is that if you target one hallmark, because these, as I said earlier, these gerotherapeutics have broad effects, but they typically target one hallmark mostly. They have these downstream effects on other hallmarks, as illustrated here, and ultimately, you have effects on multiple different chronic conditions downstream is the way we think it works. So I want to end up very quickly with education. Many of you were at the International Gerontology Congress, where we had a meeting that led to this paper in terms of training next generation of translational geroscientists. There are huge manpower needs. We need to train, the workforce. And basically, I want you to highlight two geroscience education grants. Actually, the only two NIH geroscience education grants are both at UConn, and one is the Geroscience Education Training Network, for which I'm Contact MPI, which is working to developing curricula for medical students, geriatric fellows, and PhD trainees. We also run a certificate in geroscience research program, and we are now working on, we're expecting a notice award any day now at an award that will be based at the Gerontological Society of America, the GSA, to allow much broader dissemination of these curricula in the future. And we also have an undergraduate program, geroscience education program, led by Ken Campolone, an autophagy expert on our faculty, who has developed courses in geroscience for undergrads and experiences in translational geroscience. So all of this to say is that it's a team sport. In my view, to be successful, you need to cover the spectrum from lab bench to all the way to health policy and everything in between. These are the functional domains that our center focuses on. And this has really allowed us to do this. And I want to just end up by saying that if we talk about hallmarks of biological aging, which is the focus here, you cannot ignore lifestyle choices. This is an illustration of the Life's Essential Eights that the cardiologist developed. I'm not going to read them, but all of these, everybody's familiar with the importance of all of these lifestyle aspects, which have a really important effect on biological hallmarks of aging and bidirectional effects. And finally, the geriatric 5Ms are also incredibly important in terms of applying this in a way that makes sense for older adults, to be mindful, focusing mobility, what matters most, medications, and multimorbidity. And ultimately, all of this is involves social determinants of health, because one cannot ignore those aspects, which are such important drivers of health and biological aging in populations. And this is why this is a new clinic that we opened up last year, which provides one-stop shopping, multidisciplinary shopping. All the disciplines come to the patient, provide full spectrum of care from geriatrics all the way to highly specialized care. But more important, as importantly, we focus both on geriatric care, because that's what geriatricians do, and also healthy aging and everything in between. Because I strongly believe that one needs to address both. And I would just thank my collaborators, and I'm going to stop here. Happy to answer any questions.
Oh, this was absolutely phenomenal. Thank you so much. And we have a lot of questions in the Q&A,
okay,
and some extra questions that I would like to ask, but I will be respectful to our audience and start with their questions, if that's okay. One of the questions was regarding the geroprotectors. And the question was, is actually metformin now being studied in trials together with rapamycin, specifically for immune modulation and also longevity?
So I'm not aware of that. It may well be. I'm just not aware of it. We're not. You know, there's a lot of work ongoing in this space, and it's hard to keep up with it. You know, a lot of it is reported. You know, people in the U.S., if you're funded by NIH, you have to it's required that you deposit this details in a website called clinicaltrials.gov. But obviously that doesn't apply to people in other countries. So it's you know, the issue of combinations is attracting a lot of attention. You know, I mean, again, and but studies need to be done in mice first. You know, I think that as I showed very briefly, even when something conceptually, like use of senolytics to enhance vaccine responses, even if conceptually it seems very attractive, when you look in mice, and again, mice are not perfect models, but when you look at mice, it's clear that it's much more complicated. So these studies need to be done. We are doing some studies testing combinations of metformin and senolytics in mice, but those are ongoing. You know, so but I do agree that combinations of gerotherapeutics need to be studied. Also, combinations of gerotherapeutic drugs with lifestyle interventions absolutely need to be studied.
That's wonderful. Another question was also regarding this topic, that some of the practitioners right now are a little bit concerned in terms of metformin because of the promotion of lactatidosis or acute conditions, potentially also muscle mass loss. What is your take on that? And potentially, you know, how can we modulate the dose and also the population?
No, it's a great question, and I think that, you know, I think the person, whoever asked the question, is referring to work by Charlotte Peterson showing that metformin in the context of resistance exercise may attenuate some of the benefits, you know, benefits of exercise on muscle mass. And I think these have to be kept in mind. You know, I think none of these drugs are perfect, and this is why same thing with SGLT2s and GLP-1 RAs. You know, there's incredible excitement about them. You have no idea how much work is being ongoing right now, but there's concern that as exciting as these drugs are potentially for their beneficial off-target effects, and I just mentioned mobility, I mentioned prevention of severe COVID infection outcomes. There's a lot of concern that we don't know much at all about the effect of these drugs on sarcopenia as such, and that needs to be studied. And there's some suggestion that it actually may be negative. And I think the NIA has made it a priority to actually study these drugs in older adults. So I think, to me, the lesson is that simply because we applied the word gerotherapeutic to a particular intervention, it doesn't mean that it's going to work for every condition of aging. It doesn't mean that it's going to work in everybody, even if it works sometimes for multiple, you know. So these are complicated issues.
That's really great. And another question I think is already being answered by your last slide. The question was if the concept, or how possible is it that the concept that you were referring to will be translated into clinical protocols in longevity?
Yeah, so I'm very interested in it, and I know this. So are you, and many in the audience. So I personally think that I'm a Big Ten type of a person, and I think that when it comes to care of older adults, it involves many different people. You know, it's a team effort, obviously. I feel quite strongly that you know that geriatricians who take care of older adults, and what geriatricians do is focus on people who already are frail, who have multiple morbidity. Many geriatricians have told me they can't focus on prevention because they're taking care of all these people who are frail and in some cases disabled. My answer to them is that you can't do one without the other. They must focus on, I think geriatricians also have to focus on health prevention, because, and when I say health prevention, I'm saying primary, secondary, and tertiary. I strongly believe there's a place for prevention in young people. There's a place for prevention in older adults who've aged incredibly well. There's also a place for prevention in older adults who already have multiple chronic conditions to prevent the next one and help maintain function. And conversely, I think that, you know, if I was a patient, you know, seeing somebody who runs a longevity clinic, I would want to make sure that they focus not just on longevity, but they also focus on health span, on function, and help me prevent these chronic diseases. You know, so I think that this needs to be done together. I really think that I think it would be a mistake to try to do it separately. But that's just my personal view. So at least at our institution, we've tried very hard to bring this together. And by moving to a new location, we've been able to, this may be kind of, I don't know if this is the case in other countries, but in the US, the healthcare system is very fragmented, and our patients have to navigate multiple specialists, you know. So we've tried to bring the specialists and the primary care providers to one location so that we can work together. But we've also tried to focus, like I said, both on treatment, but also prevention. And finally, we're working very hard to link our clinical practice closer to our research, and so that they can support each other. I can't hear you, sorry.
Apologies.
No problem.
Is it good now? So
Yeah,
I agree fully, and thank you so much for this comment. It's important also from the perspective that once a clinic is also working alongside with other disciplines, we are enhancing exactly this effect of working both on the health span and the sick care, and it's, you know, it's so reciprocal.
no, I totally agree.
Another question from the audience was referring to peptides. If there is a benefit of peptides in terms of them being geroprotectors, I guess we are not only referring here to GLP-1s, but maybe a little bit of a broader perspective.
When you say peptides, you mean, I guess, is it nutritional interventions or peptide therapy? I'm not quite sure if I understand the question.
I believe the colleagues are referring to peptide therapy.
Okay. No, I mean, I think there are many different approaches, and you know, I think that and you know, no one knows more about this than Alex. I mean, there, you know, traditional drug design is just one approach. There are many different approaches in aging that I think deserve attention, just being one of many. I mean, there's so much opportunity, which is why, you know, the training issues are so important, because there's no way in the world we can do it. We can do it alone.
All right, I have a question. So as someone who, you know, put now the 10th drug into human clinical stage,
right?
And I just completed phase 2A with safety and efficacy in IPF. We just saw the you know, BioAge trial being halted for their apelin receptor inhibitor, and due to liver toxicity, right? And to my understanding is that it's actually pretty mild. Most of the drugs that we call geroprotectors nowadays, and most importantly rapamycin, they do have some tox profile that, you know, right now, if these drugs were to go through clinical trials again in phase 2, phase 3 studies for chronic diseases, it probably would not have been approved again due to the tox profile and the tox liabilities, specifically for liver and nephrotoxicity. How would you kind of assess the risk-benefit scenarios for utilizing some of those drugs in humans for longevity? Because, of course, it looks like rapamycin is the front runner right now. There are not that many drugs that are significantly better in the preclinical stage, at least from the life extension. And the other feature is, what do you think is going to be kind of the trade-off between tox and benefit? And how do you balance it as a physician, and also in the context of maybe a longevity clinical trial and a potential kind of FDA view on that?
Right. And that's a great question. And obviously, I don't have all the insights, but my sense is that the decision to, by a number of groups to focus initially on diseases that did not have a treatment, such as interstitial pulmonary fibrosis, for which the only treatment is transplantation, and which is typically not available for older adults, or Alzheimer's disease, for which we still don't have treatment. It makes sense because the approval was much easier, obviously. And I think that's also, to me, the attraction of focusing on vaccine studies, because the outcomes are so much shorter. It's a real challenge. I think that that's a whole separate talk. And I was going to say that I'm happy to come back some other time, because I know I covered a lot of territory. I'd be happy to come back and speak in more detail about any one of the topics I touched upon today. One of which is how do we move more quickly from observational data to clinical trials, and particularly avoiding the kind of association bias that confounding that one gets in observational studies. That's a topic I'm very interested in, and I'm really concerned that everybody wants answers, everybody wants randomized controlled trials, but doing them is incredibly difficult, and the challenges are huge, such as what you mentioned, is that, and particularly when you're treating people who are relatively healthy, the bar is even higher for obvious reason, So it's difficult, and the traditional randomized controlled trial design, which is the gold standard, has its problems. One of which is how long it takes, how much it costs, and the third one has to do with that paper from New England Journal of Medicine that I showed, where I feel very strongly, and many prominent biostatisticians agree with me, that not mentioning the journal, not even allowing the authors to mention a positive outcome that was predetermined simply because it was a secondary outcome, not a primary outcome. I don't think that's right. I think it's troubling for a number of reasons, so I think that's a whole separate topic that we need to give a lot more thought to.
Thank you. That's again, I think that's a dilemma all of us.
Oh, it is. Yeah. I'm actually going to have to run to another meeting. I just realized that I was.
Thank you so much.
My pleasure. I'd be happy to come back any other time. And please, if anybody has any questions, just email me. It's my last name, Kuchel, @uchc.edu. So happy to, and good to see you both. Take care. Bye-bye.
Thank you so much.
Thank you. Bye-bye.
Thank you.
Thank you. And thank you, everybody, for joining.
Thank you so much, Professor. And for everybody who's still with us, please visit longevitydegree.com for our website for more courses. And of course, follow us on social media, LinkedIn, to read the newsletters, and follow us for more information about upcoming webinars. This was the final webinar of the year. So thank you very much for everybody who attended. And the video will be online on our YouTube channel very soon. Thank you, and have a good rest of the day.
Stay young and healthy.
Exactly. Goodbye, everyone.
Have a great new year. Bye-bye.